Evening, everybody. Nice to see you all. This webinar is going to be recorded, so please don't worry about trying to catch everything. We will send it out to you as a link on your email, and it will go up on YouTube as well. You will have, before you join the session, some of you will have submitted questions anonymously, and so we will answer some of those, but also you can post in the chat, which you'll find a chat icon in the bottom right hand corner throughout the call if you want to, but just be aware that your name will be visible against anything you post in the chat. So we are Dr. Sally and Dr. Deepali, and we are menopause specialists here at VOI. Today we're going to be talking through some of your questions, answering anything to do with sex, libido, vaginal symptoms, anything that you might have wanted to ask before but wasn't sure how to, or to be able to talk to your doctor about. So without further ado, I think Deepali was going to go into the words and terminology that we use when it comes to sex and libido.
Yeah, thanks, Sally. Hi, everyone. Lovely to meet you. I thought I'd start by, when women tell me I've lost my libido or my sex drive is gone, it can mean very many different things. For some, it's about the mind. They don't feel in the mood or never think about sex anymore. For others, it's about the body. They want to have sex, but when they try, nothing seems to sort of switch on physically. And for many women, it's actually a mixture of both. And that's why I think one of the first important steps is understanding that libido, desire, and arousal are not the same thing. They overlap, but each one plays a different role in sexual well-being. One of the ways I like to explain this to ladies that I see in clinic is with the image of a fire. So libido is actually like the logs of wood, your natural fuel, your biological drive, and testosterone helps provide that fuel. But in perimenopause and menopause, the pile of logs is naturally getting smaller. Desire, it's like the spark or the match. It's the decision to light the fire. In earlier years, the match strikes easily. But in midlife, desire often becomes responsive, and the fire only lights once intimacy has started, and that's actually completely normal. Arousal is like the flames and the warmth. Once the fire catches, your body responds, lubrication, swelling, warmth, and sensitivity. So if the logs are scarce, the fire burns weakly. That's low libido. If no match is struck and the fire doesn't start, that's low desire. If the logs are damp and don't catch, the warmth doesn't come, that's difficulty with arousal. So just like tending a fire, all three parts need to be supported. You can add fuel with hormones if you need. You can make the spark easier to catch with the right context and intimacy. And you can fan the flames by looking after your vulval and vaginal health. So really, I just wanted to say that the key is that libido is not a simple switch. It's a balance of your fuel, your spark, your flame. So your biological drive, your mental desire, and physical arousal. And obviously perimenopause and menopause often affects all three, but all three are treatable. And most importantly, your sexuality does not have an expiry date. And with the right support, you can feel confident, comfortable, and connected again. Over to you, Sally.
Oh, absolutely. And, that really chimes with a lot of the questions that we've been getting. So in the words of some of the women that have written in with questions, women have been saying here, so I've got, somebody saying my sex drive is non-existent. I don't feel like me anymore. Somebody wrote in that they were recently in surgical menopause. So that's if your ovaries are removed. And this is really difficult because you can go crashing into menopause, and that's really, really hard. Saying I have absolutely no desire to have sex ever again. I don't even want to cuddle. So this is really lots of women, however they're going into menopause, whether that's surgical or reaching perimenopause, just feeling that like their libido, the logs of the fire that you were talking about, Deepali, it's just gone out the window. And so should we talk a little bit about sort of perimenopause and the lead up to menopause? Like what's what's happening to libido and why that's going on?
So I mean, there's multiple reasons really. You've got biological reasons. So as estrogen's dropping, your vaginal and vulval tissues become drier, thinner, less elastic. That obviously causes discomfort, soreness, and pain. And that's obviously going to switch off your desire as well. Testosterone's also declining, and that reduces the natural background drive. You've also got physical symptoms. So if you're getting hot flushes, night sweats, poor sleep, achy joints, bladder problems, that leaves you exhausted. When you're exhausted, you don't really think about sex. And then this chapter in our life, you know, midlife, you know, people are caring for children, caring for older children. You've got empty nest. We've got elderly parents. We're juggling stressful jobs. People have generally reached, you know, a high point in their career. They're having stressful lives, managing relationships. And these stress levels, when they're high, affect body confidence. And in long-term relationship, desire often shifts from being spontaneous to being responsive. So it's rarely just one factor. You know, it's all of these all thrown in together.
It's the whole picture, isn't it? And to add to that list, some people may also be on medications. Very common ones can affect libido. So antidepressants can affect the ability to reach orgasm. Contraceptive pills can reduce libido because of the effects that they have on the available hormones. So there may be other reasons like that as well. And yeah, exactly as you've described, really, you know, if your body is so affected by menopause and you're sweating and your hair's thinning and you're, you know, that might be feels like one of the last things that's on your mind. But it's not just yours to fix. I think, you know, a lot of women maybe come to us, don't they, in clinic and say, my libido's on the floor, I need to fix this. But it's if you're in a relationship, it is on both of you to, you know, there may well be things with your partner that's possibly affecting their libido too, and their body image and how they feel at that time too. So being able to talk about it, both of you, and both address what you might need to do to enjoy sex again. You know, I think that really does come into it as well. A lot of men at this point as well might have perhaps low testosterone themselves, or erectile problems, or stress themselves as well. But also that you don't actually have to be in a relationship either to want to seek some medical help about your libido. I think sometimes women have been dismissed, you know, they're not actually talking about it in the context of marriage or relationship. And it's absolutely, you know, you have the right to be a sexual being and enjoy libido, you know, without necessarily that. So yeah, it's complex, isn't it, Deepali? There's lots.
Absolutely. And it's not, again, like everything, a one size fits all answer. Everybody is this unique, amazing human being. We're all wired differently, and there are so many nuances. But sometimes it often helps when somebody listens to your whole story and they can pick all the individual bits apart to try and come to a sort of solution to help.
So what do you think? What that actually brings us on nicely to some of the questions that we've had about what could we do naturally to boost sex drive, because we can talk about testosterone afterwards after this, but you know, what there's lots that we can do other than testosterone to help with libido and feeling sexual again. So
yeah, I mean, one of the things that I would say first of all is get the symptoms under control first. So, you know, if you've got vaginal dryness, we can sort that out, and we can talk more in detail about that. If you're having hot flushes that are affecting your sleep, that needs to be sorted. So, you know, it's almost a priority level of sorting through stuff until we sort of get to the top of the pyramid. I think exercise, this improves mood, circulation, and actually your body confidence. Sally, yeah.
Yeah, absolutely. So, and even straight after physical activity, even if it's a walk or something, you'll be warm, you're energized, your blood flow to genitals is already increased. A lot easier to get into sex and start and actually spark the fire, as you said, Deepali, with arousal when blood flow is already there, compared to, especially it's getting into autumn, winter now, being cold and sitting there, you know, in the evening and really having to be like, right, let's, you know, let's get motivated. So, and also actually the cycle of sex. So although sometimes the last thing you might think of is wanting to have sex, having sex actually increases blood flow, releases endorphins, it reduces tension, and then you kind of get that confidence, that spark a bit again, and that can be a positive cycle as well. So somehow getting into that cycle is you know, can make a massive difference too. And what do you think about sort of the approach that perhaps couples should have with sex? Because do you think I feel like that probably changes a bit in menopause as well, because
but again, you know, it depends. We're at that chapter in people's lives when they're busy and they're rushing, things are stretched. It can be really hard to have forgotten that, you know, when you were with somebody in the beginning, you had intimacy time. You did make that effort to go out, you know, sort of 30 minutes, just reconnecting can be so important without kind of all the other stresses and strains that go on.
And enjoying enjoying just the intimacy of it, and you know, because there can be a lot of focus on orgasm when it comes to sex. Like there's this, I suppose, preset idea, perhaps formed from culture and films and things, that you know, that sex involves penetration if it's heterosexual sex and then results in orgasm, but actually that it can be about intimacy, it can be about cuddling, as somebody mentioned, and apparently only 18% of women orgasm from penetration alone. So you know, what can really help in menopause is to shift the focus to stimulation, external stimulation, and there's something called sensate focus therapy, which I'll put on the chat just here, which can be a good way for couples to approach sex, especially if things have been painful or you're finding it difficult to get into it. Sensate focus therapy can absolutely help. Yeah, and actually somebody asked that they had difficulty getting into the mood, and that arousal bit that you mentioned, Deepali, that kind of spark flame, saying that they find themselves creating a fantasy story in their head to keep focused on sex, and then they feel guilty about their mind being elsewhere and taking connection away from partner. But actually visualization and fantasy are absolutely a normal part of sex.
Absolutely. And it's also to remind ourselves that a lot of women compare to, but when I was younger, I would just be able to, like I said earlier, spontaneous. Actually, we change when we get older, and we are now responsive. So it has to start somewhere, and that is completely normal. So knowledge is power. And a lot of time normalizing how a woman feels is quite powerful in itself.
Absolutely. And I guess while we're on the subject of, you know, sex and arousal and everything as well, there's, I guess, a couple of particular tips that can be really helpful. Is that pelvic floor exercises are often talked about in terms of leaking urine and things like this, but actually they can improve orgasms. And by strengthening the pelvic floor, that can improve orgasm. And also, what people don't talk about with pelvic floor exercises is the relaxation stage of it. So you tense your pelvic floor, and then it's really important to fully relax it. And the relaxation of the pelvic floor can really help with it literally trains the muscles so that you don't feel as tense during sex as well. I would recommend on any social media putting in pelvic physio, because believe it or not, there are physiotherapists specializing in the pelvic floor, and they are, you'll find them on, there's lots of pelvic physios doing some really good work on Instagram, teaching you how to do pelvic floor exercises and the relaxation bit of it as well. So definitely worth a look at. And you can also ask for a referral to a pelvic floor physio too, because they can be really helpful and specialist on this as well. Do you think we need to talk about vulvas, because I suppose this ties in so much, doesn't it? Because
absolutely.
One person has asked, what is the best thing to use to moisturize the skin on the vulva? Because a lot of products talk about vaginal dryness, but not the external skin around it. So should we just talk words a minute, like the vulva, vagina, what's the difference?
So actually, Sally, I think you had a good diagram. Do you want to show everybody the diagram, and then we can talk about what we would put where? I think that would be really useful.
Yes. Okay. So before the meeting, I just thought I would draw a very anatomically correct picture with a Sharpie and a Post-it of a vulva, because talking about where to put treatments, because basically you will find that estrogen creams will come with an internal applicator, and you're just told to put it inside. So it's called a vaginal treatment, but the vagina refers to the internal tube only, and the vulva refers to all of the external parts. So I will use my pen as a pointer. So clitoris, that's the urethral opening, there's the vagina there. And basically, when you use estrogen cream, you can apply it all over anywhere on the vulva. So clitoris, it will actually help improve sensation and reduce any discomfort here. Labia minora, the inner labia, the inner lips, around the entrance of the vagina, and then also particularly the posterior fourchette, which is this bit down here where the labia meet. And that's really important, because for a lot of women, pain during sex, if they've started getting menopausal symptoms and dryness and discomfort, is actually focused on the posterior fourchette, because this bit gets stretched when you have penetrative sex. It's a bit like the bit of your thumb just there. So that bit gets stretched. So it's super important to put estrogen cream here as well. I've even included the anus on my picture, because you can also get any symptoms that you get vulvally, dryness, itching, soreness, discomfort, can happen perianally as well. So you can apply treatments to the anus, whether that's moisturisers or vaginal estrogens or anything, just the same as you can to the vulva as well.
Yeah, and if you are, if you don't have a vaginal HRT, you can use things like plain emollients, hydromol, epiderm, coconut oil. They're all very safe. You can use them as many times as you want. As Sally said, all around the vulva, the clitoris, and especially at the back area, that's a very common area. And once it can split quite often, a very uncomfortable thing that you want to kind of avoid happening.
Yeah, and I guess also thinking about that barrier, thinking about moisturizing, what's happening with the vulva and vagina and perianally in menopause is that estrogen levels are dropping, and that can cause breakdown of the barrier. So normally skin should be a good barrier where it's really moist and keeps things from irritating the surface. So once estrogen's breaking that down, that barrier's gone, and that's why everything's more sensitive. So the moisturizers that you're suggesting there, Deepali, is really it's really important to rebuild that barrier. A lot of us kind of overwash as well, we use soaps as well when we're washing vaginally, and we don't need to, and actually soap strips the skin of its natural oils and moisturizers. So you can actually buy really cheaply, and you can get it in big tubs, aqueous cream. I'll put the name in the chat, which is basically from supermarkets and pharmacies, and you can use that as a soap substitute, and that will even that and then the moisturizers that you suggested, which I'll also list in the chat, can be so helpful even if you're not using estrogen cream.
And as we get to this sort of perimenopausal, menopausal chapter in life, the pH of our vaginas are changing. And so actually water and using all these things are much better. When you start using perfumed products down below, actually you're just putting yourself more at risk of getting things like thrush and causing sort of irritation down below.
Yeah, absolutely. And so it's not just dryness, is it? There's so many different symptoms that can happen. Can be really sore for some women, even just wearing sports leggings or sitting on a bike or anything. Wiping with loo paper can just be extremely sore. Yeah. So anything else about vulvas, do you think, before we move on to you actually using testosterone? I know we've had a lot of questions about that.
I think we've covered it.
And if anybody would like to post any Q&As in the chat, or we can answer anything else at the end, please do. So testosterone, where would you like to start with that, Deepali? What should we say? Plenty to say about testosterone.
I guess people want to know why, what's happening with our testosterone. Levels naturally decline with age, don't they, Sally? And there isn't a clear cutoff that defines deficiency in women. So actually, we want to look at symptoms rather than numbers.
Yeah, so somebody's asked, what's the next step after a blood test shows low testosterone? So yeah, I think levels gradually decline from age 20. It doesn't like drop off in the same way that other female hormones do in menopause. So for women, there's no known sort of like what is a low level for women. Perhaps with more research, we might characterize that more, isn't it? But at the moment, we mainly use a blood test to make sure that it's safe to start treatment.
Yeah, I mean, some conditions can give you a raised testosterone, and really we don't want to be prescribing testosterone if you've already got a raised level, because you're more at risk of side effects. And I always like to think about testosterone as a room in a house. The house is the other things, so your other hormones like estrogen and progesterone. And once you've sorted those out, then you can look at that room and sort that one out. Testosterone really works much better when you've been adequately estrogenized and we've sorted out your HRT.
Yeah, which is why usually you won't be able to use it straight away, and that's for good reason, isn't it? You need to have good levels of estrogen first. Yeah. So we've talked about the cutoff, and we've talked about how it can decline naturally, but basically the guidelines for using testosterone are to treat libido, and that is a persistent lack of libido that's been for 6 months or more, and that you're bothered by it. So some women feel that low libido in itself is something that might need treatment, but you don't necessarily need to treat low libido alone if you're not bothered by it. So if you think, I'm all good, thanks, I don't need or want sex in my life right now or whatever, then that's fine. You don't necessarily need treatment, but do it for yourself. If you're bothered by having a low libido, absolutely you can have treatment for that. And somebody has asked whether testosterone helps with other things alongside libido.
So at the moment, the strongest evidence is really for sexual desire, arousal, orgasm, and satisfaction. But there is emerging evidence that it might help with mood, energy, and concentration. But the research is ongoing at the moment. I think there's a trial in the UK called Esteem, and that's a huge, big trial that's looking at that. So I guess we wait for the results of that to come out.
Mm-hmm. Yeah. This is really exciting, and I hope this adds to the body of research, because it's well recognized in men that low testosterone can cause depression, fatigue, and it's considered a serious health condition. And women, we have about 10 times less testosterone than men naturally, but it is a hormone that we have. We shouldn't consider it a male hormone. Both genders have testosterone, and I think that's historically perhaps been why, I'm sure some women on the call may have found that they haven't been able to get testosterone treatment, and I think that's for a number of reasons, and I think it's probably partly because of how we've historically viewed it. So more research is coming for women, and I think there's definitely good grounds to have an understanding that testosterone is linked very much so to energy and brain function. So lots of women are reporting that those things improve when they're using testosterone treatment. What's really hard is to characterize this at this moment and match it to what the evidence is out there. So more evidence is coming. let's hope it's soon. Yeah. So we are nearly out of time. Is there, and there's a question in the chat, how old do you have to be relevant, like to be considered for vaginal estrogen or testosterone treatment? Yeah. So Deepali, what do you think?
Well, I don't think, you can be dry vaginally at any age, to be honest. And, I've had patients, young patients in their 20s, who find smears very uncomfortable and very painful. And, we can give it to them before they have a smear. There's very little risk associated with vaginal estrogen. Obviously, again, it's on a case-by-case basis, but I wouldn't say that there is as such.
No, and we've even had women, I've even used vaginal estrogen for women during breastfeeding, because in breastfeeding you've got this depleted estrogen state, and it can be so helpful. So there's actually, almost age doesn't come into it at all. If you've got vaginal or bladder or vulval symptoms are likely to be related to low estrogen, absolutely you can use it. It's so safe as well. So what was the fact that I had? It was that, so a year's supply of vaginal estrogen cream is the equivalent to only one HRT tablet of estrogen. So it's so safe. And as Deepali said, there are individual situations where things might need to be considered. Let's say if a woman has had a breast or gynecological cancer, then there might be certain situations where we may not be able to use estrogens, but it is extremely unusual and only really specific cancer situations usually. Absolutely. And what about testosterone treatment? What do you think?
I think testosterone treatment, we, really want to be looking at for women in the area that I'm in is after once they're on HRT. But, again, you're treating a woman clinically. She could be under 40. She could be having problems with hormones at that age. So again, it's a case-by-case basis, and I wouldn't be. I don't want to put a level on anything, because then we risk excluding people. Yeah,
the guidelines for testosterone specify that we do need to use HRT with testosterone at this point to make sure, as we've said, that adequately estrogenized. But there's nothing in the guidelines about age, is there? It's on the basis of libido that's bothering you.
And the reason for that is because it works better once if you've got enough estrogen going on. Otherwise, it's not going to work that well.
There is another question in the chat, which is, why is my bladder function suddenly affected with soreness and discomfort? I've been using estrogen cream for 5 weeks now and on HRT for a few years, and this person, it feels like it's come out of nowhere. Any thoughts on that?
Well, it's very individual. How often are you using the vaginal estrogen? Now, generically, when you get the instructions, it'll say to use it for 2 weeks and then once or twice a week. But some women need to use it every day.
Sorry, go on.
Go on, sorry.
No, I was just getting excited because it can take 3 or 4 months or even longer for estrogen levels to really build really slowly. So a few weeks is possibly not long enough for a lot of women, because if you imagine, if your estrogen levels have been low for a long time vaginally, then it's going to need a lot of time to build up. So persevere every night, and the prescription might say use every night for 2 to 4 weeks, but actually you can use it every night for as long as you need to for your symptoms to be controlled. And then the kind of motto, I think, is like estrogen cream for life, in the sense that you have to continue to use it perhaps on as a maintenance, like getting lots of hearts on that one, because you know, you're going to have to use it for maintenance, probably twice a week. Once your symptoms are controlled, you can drop it down to twice a week, but carry on using it, because if you stop using it again a few months later, once things are better, then estrogen levels will just go back down again, and symptoms can restart. So
and there might be times where, you know, maybe at some point you use it twice a week. There might be times when you need to use it 5 times a week. That's all okay. And just going back to the question about sort of the time, usually when we start a medication, we review you in 3 months. We like to give it 3 months for really any kind of hormones to settle in and work.
Yeah. And this coming out of nowhere thing, you know, so menopause shifts and changes over a number of years. So, you know, you can start with some symptoms at the start of perimenopause. Let's say most commonly it's sleep and mood changes. Then other stuff kicks in, like your cycle and your periods start noticeably changing. Then perhaps vaginal symptoms come in a bit later. And so that's the classic, but it can be so individual. So lots of women will over years have certain shifts. It's really tricky, isn't it, with menopause, because you think you're winning, you've got a formula, and then something else shifts, and then so you might need to be adaptive and change your treatment. So yeah, it's really good that you've started the estrogen cream now, the person that answered that question, and that should really help. Great. Where are we? I think we're out of time. What do you think are have you got, this would challenge you, Deepali, have you got 2 sort of key messages that you would want to sort of take away from tonight's session to wrap up with? Any two particular points that you think?
I think, you know, we didn't actually use we didn't mention vibrators, and they're incredibly important tools. They're actually medical tools, and I think the conversation should be more open about them. You know, I discuss the use of them with patients all the time. Women often feel more confident rediscovering their own bodies before then taking it into, you know, a partnership. So I just wanted to mention that. And also about sex, make sex comfortable first, because once you've removed pain and you feel okay down below, desire and intimacy, it's almost you've given them a space to return again.
Absolutely, yeah. Get your menopause symptoms treated so that you're not suffering and you feel better in yourself. Get lots of moisturization into your routine, vaginal estrogen if you need it. And my key message would be focusing on externally. So vulval skincare, treat your vulva like you would your face with lots of care and moisturizing. Get the estrogen cream on the outside too. And with your partner, a focus on clitoral sensation, not just penetration, and bring that enjoyment back in. Absolutely.
And just I wanted to pick you up on that, Sally.
Oh, yeah.
Amazing comment. We all look after our faces. We moisturize our faces. We should be doing the same with our vaginas and look after vaginas just the same.
Absolutely. Amen. So I think we'll finish on that note, shall we? Thanks everyone for joining.
Thanks everyone for joining. Thank you.
And, we'll send you the recording on the email so you can always refer back. Take care, everybody. Bye.
Bye.